Hello. In this video, we are going to look at an approach to oncocytic lesions in the thyroid gland in thyroid FNAs, and this will be discussed on the background of the Bethesda System, the third edition. So this is an overview of the 2023 third edition of the Bethesda System for Reporting Thyroid Cytopathology. This is a 6-category system: non-diagnostic, benign, AUS, which stands for atypia of undetermined significance. There is a separate video giving an overview of this AUS category: follicular neoplasm, suspicious for malignancy, and malignant. So first of all, when thinking about oncocytic cells, and the Hertel cell is the older term referring to cells of this appearance, but moving forward with the WHO latest histology blue book, the term oncocytic is favored over Hertel cells. So these are cells with abundant granular cytoplasm, and sometimes this cytoplasm appears rather dense, especially on the air-dried smears, and the cytoplasm is usually full of mitochondria. So let's start by appreciating the spectrum of differential diagnosis. First of all, this could be non-neoplastic lesions, for example, a colloid nodule or a benign follicular nodule with areas of oncocytic change. Usually we will see background features of benignity, such as colloid and non-oncocytic cell populations. So usually there will be two cell populations, oncocytic as well as regular-looking follicular cells. Lymphocytic thyroiditis, which includes Hashimoto thyroiditis, is another non-neoplastic condition where we can quite frequently see oncocytic cells, and one of the clues, of course, is that we can see lymphocytes in the background. The other clue is that the oncocytic cells often have quite a significant variation in cell size, and the nuclei can range from small to large. Then we have the benign neoplasms, which include oncocytic adenoma, previously known as Hertel cell adenoma. And in this instance, there will be very little colloid. The cells tend to be more dispersed, and we may also see binucleated cells, and sometimes we can see traversing vessels within larger tissue fragments. And then there are the malignant neoplasms, which include oncocytic carcinoma, previously known as Hertel cell carcinoma. And there are other malignancies such as papillary as well as medullary thyroid carcinoma, which can sometimes have an oncocytic appearance, but in this instance, the nuclear features are very important for the correct diagnosis. Now, when we look at oncocyte-rich lesions in the context of the Bethesda system, they can fall into several categories. First of all, benign. And usually this will be a mixed oncocytic population. We can see oncocytic and non-oncocytic cells, as I mentioned, for example, a colloid nodule, or we can see oncocytic cells together with lymphocytes in the context of lymphocytic or Hashimoto thyroiditis. If we do encounter a pure oncocytic population, this can also be categorized as benign if the oncocytes are arranged as cohesive flat sheets and they are bland. There is abundant colloid in the background, and there are no clinical or radiological high-risk features, then this can be called a benign thyroid nodule. Now, oncocytic lesions can also fall into other categories such as AUS, atypia of undetermined significance, and oncocytic follicular neoplasm, and this is when we see an exclusive oncocytic population without background lymphocytes. And when I say oncocytic population here, I mean that the cells should not have nuclear features of papillary thyroid carcinoma or medullary thyroid carcinoma. So this can fall into the AUS other category, oncocytic atypia. For example, if there is a hypocellular nodule with almost exclusively oncocytes and minimal or no colloid, or a more cellular smear where there is an almost exclusive oncocytic population, meaning that this looks like an oncocytic neoplasm. However, the clinical features suggest a more benign etiology. And in these nodules, there should be no lymphocytes, or there are multiple oncocytic nodules with features of neoplasm, but the clinical picture points to a benign picture. So this will also be classed into AUS other. Oncocytic follicular neoplasm should have quite specific findings where the aspirates are cellular, almost exclusively composed of oncocytes, no papillary thyroid carcinoma or indeed medullary thyroid carcinoma nuclear features, and the cells can be arranged as more dispersed cells or in more cohesive sheets, crowded groups, and sometimes with traversing or transgressing blood vessels. As I mentioned earlier, there sometimes may be binucleation or prominent nucleoli, minimal colloid in the background, and no lymphocytes. The risk of malignancy in this instance is about 25 to 50%. So looking at the Bethesda system as a whole, oncocyte-rich lesions can be benign. They can fall into the AUS other category. They can be neoplastic. They can fall into suspicious for malignancy category as well. And they can also be malignant in the context of PTC or medullary thyroid carcinoma with some oncocytic features. And in this instance, we would not call this a malignant oncocytic tumor, but rather just malignant papillary or medullary carcinoma. And just take note that these malignancies can initially appear oncocytic. So here is an example of oncocytes or oncocytic cells in a thyroid aspirate. And if you just look here, it looks like quite a pure population. However, the rest of the smear shows abundant colloid, and it also shows non-oncocytic cells. So this is just a benign nodule with an oncocytic component, and this would just be diagnosed as benign colloid nodule. Here again, we can see oncocytic cells with abundant cytoplasm. However, if you look at the whole picture, we can see lots of lymphocytes in the background, and this is therefore an example of lymphocytic thyroiditis, also in the benign category. Here are more examples of oncocytic cells with lymphocytes, and you notice that there can be quite a significant variation in nuclear size. Some of the nuclei and some of the cells themselves can be very large. Here is the alcohol fixed preparation showing similar variation in nuclear size and lymphocytes in the background. And here is yet another example. Again, you can see that there is a range in nuclear sizes. We can even see lymphoglandular bodies in the background accompanying the lymphoid population. And again, here lots of lymphocytes in the background. So this would fall into the benign category, lymphocytic thyroiditis. Here is an example of a very cellular smear with these large tissue fragments, fairly cohesive, composed of quite uniform oncocytic cells. This would fall into the oncocytic follicular neoplasm category if there is minimal colloid, as we see in the background, and quite often in oncocytic follicular neoplasms, the oncocytes can actually be quite uniform in size. This is the alcohol fixed smear from the same patient. And on higher magnification, we can sometimes see prominent nucleoli within these oncocytic cell nuclei. And here are some of the features that are described in oncocytic neoplasms: the dispersion of the cells, binucleation, and tissue fragments with traversing blood vessels. These are not specific features for neoplasia, but they are corroborative. Here is another example of a smear with lots of oncocytic cells. They are a little bit dispersed here, and some of them are binucleated. So this would fall into the AUS other oncocytic atypia category if there is no colloid in the background and no lymphocytes. This turned out to be Hashimoto thyroiditis on histology. Here is another example of a case where there are clusters of cells with quite abundant, fairly dense cytoplasm. So these cells have an oncocytic appearance, but in many other clusters there was more crowding and there were some nuclear inclusions, and this is actually papillary thyroid carcinoma with some oncocytic features. Here is a different case where we can again see these cells with quite abundant, dense appearing cytoplasm, and the nuclei are actually very eccentric and fairly uniform. This turned out to be a medullary thyroid carcinoma, and you can see how closely they resemble oncocytic cells. The clue will lie in the alcohol fixed smears in the nuclear chromatin, which shows a granular salt and pepper appearance. So this is yet another differential diagnosis for oncocytic type cells in thyroid aspirates. And before I end, I would like to invite you to check out Pathweb. This is our free online pathology resource. We have a virtual pathology museum with more than 1,000 fully labeled interactive virtual pathology specimens, and registration is completely free. The link is in the video description. Thank you.